In today's lecture at Medical Sciences, we want to look at hemolytic anemias. And after defining what hemolytic anemias are, which is part of the classification of anemia, we are going to look at the causes, signs, and symptoms of hemolytic anemias. Then we look at the classification, whereby it is categorized into, so that is intravascular and extravascular. Then afterwards, we shall look at the lab diagnosis. And as we begin, we urge you to subscribe if you haven't. Those who are willing to support this cause, you can become a member by subscribing 10,000 per month, so that we can continue to support this great work, that we can serve the society. So, hemolytic anemias, the word comes from hemolysis, whereby hemolysis is a breakdown of red cells. So hemolytic anemias, they are due to increased hemolysis. Increased hemolysis of red cells, or you can say destruction. Increased destruction of red cells before reaching their 120 days. We know the lifespan of red cells is 120 days, but in hemolytic anemias, these causes are they are leading to increased destruction before these cells reach, before these red cells reach 120 days. So it is before 120 days. And this breakdown is increased that even the bone marrow cannot compensate. So the rate of destruction is greater than the rate of replacement by the bone marrow. So that is what we can tell you. And because of that, we're going to see that this destruction is heavier than what the bone marrow can compensate. And this one, because the bone marrow is trying to work hard to replace the destroyed cells, we are going to find that is characterized by increased reticulocyte count. We shall see increased reticulocyte count. And under PBF, we shall also be looking at nucleated RBCs. Then it is also characterized by jaundice, whereby there is moderate hyperbilirubinemia. As we shall see under extravascular, we shall look at splenomegaly is also a characteristic, whereby the spleen enlarges. Then another characteristic under hemolytic anemia, it is also characterized by dark urine. And this dark urine is due to the hemoglobinuria. It's due to hemoglobinuria, whereby there is the presence of free hemoglobin both in blood and urine. So we are going to find hemoglobinuria and hemoglobinemia. Hemoglobinemia. That is increased free HB in blood. Then this is increased free HB in urine. We're going to see that. So these are some of the characteristics. And even when you do thin film, you will find presence of fragmented cells, that is schistocytes. You shall see schistocytes present. Those are fragmented red cells. So this is what we can introduce under hemolytic anemias, whereby signs and symptoms, it can be mild, moderate jaundice, splenomegaly, and other signs we can see is dark urine. Someone producing dark urine is another sign. Another sign and symptom is paleness, tiredness, which are always a peculiar of anemia, plus leg ulcers. leg ulcers in hemolytic anemias like sickle cell anemia. You find someone will have leg ulcers, bone deformities are also seen. So jaundice is a characteristic of hemolytic. It is the one that portrays that there is increased destruction. And this jaundice is caused by unconjugated bilirubin type, which is found within the reticuloendothelial cells and then splenomegaly. So after looking at the definition of hemolytic anemias, and then we shall look at more under lab diagnosis. We have looked at the signs and symptoms. Now let us go straight to the classification. And among the classification, we shall have extravascular and intravascular. Extravascular means the causes are outside the blood vessels, whereby these extravascular hemolytic anemias, they occur in reticuloendothelial system, that is the bone marrow, the spleen, and the liver. And the key players under this is macrophages. Macrophages are the ones that are destroying these red cells before reaching their senile stage. And because there is the destruction of red cells, these macrophages, they come and destroy red cells to release hemoglobin, whereby this hemoglobin is broken into globin and heme. Then heme is further split into iron and porphyrin or protoporphyrin ring, and this iron is transported by transferrin to the liver and stored as hemosiderin. This globin is also taken to the liver and is stored or converted to amino acids which can be reused. Then the porphyrin is first reduced to biliverdin. Then from biliverdin, it is oxidized to bilirubin. And this bilirubin formed here is unconjugated or indirect. And this one is occurring in the reticuloendothelial system. Then this unconjugated bilirubin is transported to the liver bound to albumin, whereby in the liver it is converted to direct bilirubin or conjugated bilirubin by an enzyme known as glucuronosyl transferase. Then this direct bilirubin is transported via the bile duct to the intestine or to the duodenum, whereby it is converted to urobilinogen. And this urobilinogen, it is formed by the presence of intestinal bacteria. Intestinal bacteria acts on to form urobilinogen, whereby 99% of urobilinogen is secreted as stachybilinogen in stool. Then urobilinogen, 1% is excreted as urobilinogen in urine. So what is going to happen under extravascular? Extravascular, you can also call it intrinsic. The causes which are causing hemolysis are within the red blood cell. That's why we call it intrinsic, or we can call it intracorpuscular, because the causes are within the red cell, not from outside. And because the red cell is defect, that's why we are seeing being destroyed by the macrophages. So the causes are intrinsic. That's why we can call it intrinsic type of hemolytic anemias. So this extravascular or intrinsic hemolytic anemia, it is going to be characterized by moderate hyperbilirubinemia, which is indirect type or unconjugated. That's why we see jaundice. We see jaundice under this. We are going to see presence of urobilinogen in urine. There is increased levels of urobilinogen in urine, and stachybilinogen is also increased in stool. And because there is increased direct bilirubin and indirect, because the biliary system is overworking, we can even see gallstones coming in. So even gallstones, we can see them being formed due to overworking of the biliary system. And because the spleen, the bone marrow is overworking, we shall look at the bone marrow having hypercellularity. There will be hypercellularity in the bone marrow. Then the spleen and the liver, they are working. We can see hepatosplenomegaly coming in. Hepatosplenomegaly, whereby on examination, you can find the liver and the spleen are enlarged due to overactivity of destroying these immature red cells. That is where the signs and symptoms come in. And this one shall also give us a clue of the diagnosis, whereby some of the diagnosis we shall get them from this pathology. But the pathology of intravascular, or the causes which are within the red cells, we are going to see that these ones, we call it intravascular because the destruction is occurring within the blood vessels. And within the blood vessels, if I can draw here a blood vessel, if this is a blood vessel, we're going to see when RBCs are in this, the RBCs are destroyed within the red cells, within the blood vessels, either due to trauma or due to immune activity, leading to release of hemoglobin. And when hemoglobin is released, in the blood we have a component known as hepatoglobin. We shall see hemoglobin combining with haptoglobin so it will combine with haptoglobin to form hemoglobin haptoglobin complex. So meaning the more we produce free hemoglobin in blood vessels, the more we use haptoglobin. And this one will lead to reduced levels of haptoglobin in blood saturation. And this complex is excreted in urine. So we shall find free hemoglobin in urine. Free hemoglobin in urine, which results into hemoglobinuria. Hemoglobinuria. And there is also increased levels of free hemoglobin in the blood, which results into hemoglobinemia. Hemoglobinemia also results into that. And because we are using much of the haptoglobin levels also decreases. And this free hemoglobin is the one that makes urine to look dark. You find you have darker brown urine, which is an example particularly seen in severe malaria infection, is seen as dark brown urine. So this is the pathophysiology which occurs to bring about intravascular hemolytic anemias. So after looking at their pathophysiology, it will even guide us on the signs. So that's why we said some of the signs. Here we don't see splenomegaly because there is no reticular endothelial cells involved. But here we only see hemoglobinemia, increased levels of hemoglobin in urine. In the blood, we see hemoglobinuria or dark urine due to free hemoglobin, and we see decreased levels of haptoglobin, that is, and even increased levels of hemosiderin in urine. Here we can even see increased levels of hemosiderin. So this is under intravascular, or we can call it extrinsic, because the cause of destruction of these red cells are outside the red cell itself. It is either due to mechanical injury or due to incompatibility of blood. Or we can call it extracorpuscular. Extracorpuscular, the cause is outside. So you can call it intrinsic or extracorpuscular. And this type of anemia, these ones are acquired. This one is acquired. The mode of this is acquired, whereby the mode of this is genetic. This one is inherited. Extravascular causes are inherited. Or you can say they are genetic. So after seeing this pathophysiology, now let us look at the causes. This one leads us to causes, whereby causes of extravascular hemolytic anemias, we shall see enzymopathies, or what we call red cell enzyme defect. And for example, here we shall give an example of pyruvate kinase deficiency, and we shall also look at glucose 6-phosphate dehydrogenase deficiency. So we can even see hexokinase deficiency. So these are three causes of enzymopathies, that if in case these enzymes which are involved in glycolysis and hexose monophosphate shunt, when they are low, it brings about increased hemolysis of red cells, and we shall see how we can diagnose these different ones in the lab. So these are some of the causes when we have deficient of these enzymes. Another category under extravascular is red cell membrane defect, because we know that the membrane of the cell of RBCs are made up of a cytoskeleton, which is known as ankyrin and spectrin. And this cytoskeleton is the one that enables flexibility and maneuvering of red cells within the smaller or microvascular cells. So when there is a defect in this cytoskeleton, that is ankyrin and spectrin, the cell membrane of red cells become rigid and they cannot pass through the microvascular vessels, hence leading to breakage. And examples in this type, we find examples as hereditary spherocytosis. We have hereditary elliptocytosis. We shall have hereditary acanthocytosis and hereditary stomatocytosis. So these are the four causes. They can be hereditary, they are inherited, whereby we shall look at the diagnosis of them in details under lab diagnosis, whereby due to the defect of cytoskeleton, we are going to see there will be, this one is due to increased influx of sodium ions. Even this one is due to increased influx of sodium ions. And when sodium ion, if I have a red cell and there is more entry of sodium ions inside and there is increased levels of sodium inside the cell, water follows by osmosis and the cell becomes tugged and small in size. So this one, due to increased influx of sodium ions seen in spherocytosis and elliptocytosis, there is increased influx of sodium ions leading to absorption of water by osmosis, causing the cell to lose its area of centropera and increasing in the concentration of the hemoglobin in the cell. We shall see it under thin film. Then elliptocytosis is the same. Then acanthocytosis is seen as, which is seen in a beta lipoproteinemia, which is a defect in the metabolism of fats in the liver. We shall see how acanthocytes look like in the peripheral film. Then stomatocytosis is due to increased influx of potassium ions. That when there is increased entry of potassium ions inside the cell, if this is the RBC, and there is increased influx of potassium ions, and when more potassium ions enter, more of sodium is lost, and this cell will lose its fluid content to the surrounding and becomes prosmolized, hence attaining a kissing mouth-like shape of area of central pera, whereby the area of central pera looks like a kissing mouth or looks like a moon-like or boat due to loss of potassium ions, increased influx of potassium ions. Then other causes which are due to HB defect, hemoglobin defect, we can have those ones that affect the structure, that is hemoglobinopathies. We shall have those ones that affect the synthesis of globin. And among the hemoglobinopathies, these you can call them hemoglobinopathies. Hemoglobinopathies, we can see sickle cell. You can see sickle cell anemia. You can look at hemoglobinopathies like hemoglobin C crystals and so forth. So hemoglobinopathies, HbM, can fall under here. Then, due to hemoglobin defect, we are going to find conditions like which we call thalassemias. This one is thalassemias. And these thalassemias can include alpha thalassemias and beta thalassemias. So these ones affect the globin chain, whereby these ones affect the structure of hemoglobin. That's why we call them hemoglobinopathies. So those are also the causes, and we shall see how we can diagnose them under lab diagnosis. So after finishing the causes of extravascular, or what we are calling intrinsic, now we can talk about intravascular, which is due to destruction of red cells in the blood vessels, which is further categorized into immune and non-immune causes. And among the immune causes, we shall see those which are autoimmune. Autoimmune causes, meaning the body is producing auto-antibodies directed to destroy red cells. Then we shall also see autoimmune causes. And under autoimmunity, under autoimmune causes, we are going to see these antibodies can be warm autoantibodies, which work at 37 degrees, and others can be cold agglutinins or cold antibodies, which work at room temperature. But these ones are directed towards destroying cells of self. Your own body producing autoantibodies directed to destroy and hemolyze red cells. And these ones are always confirmed by doing Coombs test, that is anti-human globulin test, both direct and indirect Coombs. Then under autoimmune, we are going to see blood incompatibility, that is due to incompatibilities. For example, in hemolytic disease of the newborn, you can see it in the blood transfusion incompatibilities. Like if that is ABO blood transfusion incompatibilities and rhesus. When you give someone is of blood group A and you are giving them blood B, so that is blood incompatibility. And even tissue transplant rejection, tissue transplant rejection. Maybe they were transporting your kidney, but it finds it is not compatible. So it can lead to destruction of red cells. So under immune causes, categorized under autoimmune, those of self-immune, which they are being produced against the cells of self, then autoimmune due to incompatibility of cells. After looking at that, we want to look at final cause of these hemolytic anemias, which is intravascular causes. And we are going to see causes like under non-immune, these ones are due to trauma or mechanical damage. They can even be due to mechanical damage. And examples include malaria infection is one of them. We can look at hemolytic uremic syndrome. We can look at paroxysmal nocturnal hemoglobinuria, whereby someone's red cells tend to be destroyed, especially at night. That's why we call it paroxysmal nocturnal hemoglobinuria. And other causes can even include severe burns. If someone has severe burns, toxins like snake toxins like poisons, stroke drugs that induces hemolysis like sulfonamides. Then we can look at other causes like disseminated intravascular coagulation, that is DIC. We shall look at thrombotic thrombocytopenia purpura. Thrombotic thrombocytopenia purpura is one of also the causes of these hemolytic anemias, and many others. So these are due to mechanical or trauma of the red cells. Malaria infection, burns, toxins, stroke drugs, disseminated intravascular coagulation, thrombotic thrombocytopenia purpura, not forgetting paroxysmal nocturnal hemoglobinuria. So these are non-immune, but they cause stress to the red cells, leading to their breakage, whereby there is release of free hemoglobin. And as we are concluding, we are going to look at lab diagnosis. And lab diagnosis of these hemolytic anemias depends on the cause. We diagnose depending on the cause. If the cause is extravascular, we shall go down and look at, is it enzymopathy, is it red membrane defect, or is it HB defect? So if the cause is pyruvate kinase, the lab diagnosis, if it is pyruvate kinase deficiency, the lab diagnosis we can do is to determine serum pyruvate kinase enzyme. And if it is, you will find in this case, it is decreased. If the problem is glucose 6-phosphate dehydrogenase deficiency, we shall determine serum G6PD, and we find it is low, and we can even do a thin film under PBF. We are looking for presence of Haynes bodies. Haynes bodies are also present in this type of anemia, whereby Haynes bodies, you find the red cell is surrounded by dark blue staining, protruding cells. These are what we call Haynes bodies, which are peculiar of glucose 6-phosphate dehydrogenase deficiency. Then if the problem is RBC membrane defect, if it is due to red RBC membrane defect, we shall look at if this is due to maybe hereditary spherocytosis. We shall be forced to do a thin film, and we look for the presence of spherocytes in PBF, whereby spherocytes, they are small RBCs which are dense pink staining. They stained pink with no area of central pera. That is a spherocyte. If the cause is hereditary erythrocytosis, if it is erythrocytosis under lab diagnosis under thin film, you shall look for the presence of erythrocytes. Whereby erythrocytes, these are red cells which are elongated. Is an elongated red cell with no area of central pera, whereby diameter at the center is the same as at the periphery. So that is an erythrocyte or elliptical cell. Then if it is hereditary acanthocytosis due to abetalipoproteinemia, we shall look for the presence of acanthocytes in the periphery or in the thin film, whereby acanthocytes have spicules. If this is a red cell, you find this one has spicules of an equal length, spicules which are between 2 to 12 with no area of central pera. This one is what we call an acanthocyte seen in a defect of lipid metabolism. Then lastly, one under red cell membrane defect is hereditary stomatocytosis. And if someone has hereditary stomatocytosis, you look for the presence of stomatocytes in the peripheral film, whereby we said these stomatocytes, they look, if this is an RBC, the area of central pera is boat-like, it has a moon-like shape, or it looks like a kissing mouth. That is what we call a stomatocyte, which confirms presence of this. But apart from these peripheral thin film, we can also do another test for this, which we'll call osmotic fragility test. Osmotic fragility test can also be done throughout the red cell membrane defect due to ankyrin and spectrin cytoskeleton, whereby under osmotic fragility, we do increased changes of normal saline, that is sodium chloride. And if there is a membrane defect, we shall see the hypotonic solution causing cell lysis. Because in hypotonic solution, the cell will leave the red cells, hence will become hemolyzed. So we'll be looking for hemolysis according to increased concentrations of normal saline. That is osmotic fragility test, which confirms RBC membrane defect. And if the cause is due to hemoglobin defect, if it is due to HB defect, either it is due to hemoglobinopathies like sickle cell, hemoglobinopathies like thalassemias, the test we can perform is HB electrophoresis. We do HB electrophoresis to confirm. We can do a peripheral thin film. If it is sickle cell, we are looking for the presence of sickle cells, or you can call them drepanocytes. If it is a thalassemia, we are looking for target cells, and so forth, and still not forgetting presence of nucleated RBCs. And we even do reticulocyte count. Reticulocyte count is the genome that gives you a clue that someone has hemolytic anemia. So it would have come as number 1, reticulocyte count. Whenever we find reticulocyte count is high, it is a measure of all hemolytic anemias. It means there is increased stress on the bone marrow. Then another test, if the cause is due to immune That is, we have gone into intravascular. If the cause is immune, then here we do tests like Coombs. We can do direct Coomb and indirect Coombs test. Rule out to the presence of these autoantibodies. And if the cause is due to trauma, for example, malaria, we can also do a BS to rule out presence of malaria parasites. If the cause is the paroxysmal nocturnal hemoglobinuria, we can do Haemolytic test. Haemolytic test here we use an acidified solution, and if this acidified solution causes hemolysis, we use an acidified solution, and when it causes breakdown or hemolysis, it confirms the paroxysmal. It was discovered by Dr. Ham, that's why we call it Ham's test. That is for paroxysmal nocturnal hemoglobinuria. If the cause is the DIC, that is disseminated intravascular coagulation, or thrombotic thrombocytopenia purpura, we can do D-dimers and other coagulation tests. Can do other coagulation tests like prothrombin time, activated partial thromboplastin time, like that. But commonly we can do D-dimers throughout. And as we said that among all the extravascular there is increased bilirubin, other tests we can do apart from that is we can also do serum bilirubin. We can determine serum bilirubin, and we'll find it is elevated. We can look at urine urobilinogen by Scale-Singer method. Urobilinogen, it will be increased. We can do another test known as haptoglobin, and we'll find it is low because we are using haptoglobin with combining with hemoglobin. So when we find decreased levels of serum haptoglobin, when there is decreased levels of serum haptoglobin, it will confirm intravascular hemolysis. We can also go ahead to do LDH. Another test we can do is lactate dehydrogenase. Because of increased hemolysis of red cells in the blood vessel, we are going to see levels of lactate dehydrogenase, hence it will be increased in serum. So we can even do serum lactate dehydrogenase. So these are some of the laboratory tests that we can perform on hemolytic anemias. Hope you guys, you have gained a lot. And for more information, you can type under the comment section. We can be able to explain more. Thank you so much for watching from the beginning until the end. May God bless you.